Next up, we have Dr. Raje, who is the director of the Center for Multiple Myeloma at Massachusetts General Hospital Cancer Center and a professor of medicine at Harvard Medical School. Welcome, Dr. Raje. Thank you so much for being here today.
Thank you for having me, Gina.
So, over the last year or so, we've been hearing more and more about CAR T-cell therapy in multiple myeloma. So what updates are we hearing about with that at this year's ASH annual meeting?
So, CAR T-cell therapy, obviously a very different kind of modality of treatment for patients with multiple myeloma, and we first presented some of this data now a couple years back. We did an updated presentation at ASCO, and the data keeps growing. There's so much more information at this year's ASH, and I'll highlight just a couple of those, Gina, which are kind of further along in their development. So you do have the legend data, which is being presented at this year's meeting. We'd heard about it first at ASCO more than a year and a half back, and the follow-up at that point in time was relatively short, and I think we'd seen about a 6-month follow-up there. And the difference between that and the BB2121 data that we've seen is the LCAR CD38 CAR T-cell was a bispecific CAR wherein they target 2 different epitopes of the BCMA molecule, suggesting that they would have a tighter binding. And the data which is going to be presented at this year's meeting, at least the abstract looks great. It's close to 57 patients, so that's probably one of the largest single kind of center experiences with CAR T cells. There's a few differences between what we've done with BB2121 and this one specifically, and the ones which are most striking to me really are that they did not use fludarabine as their lymphodepletion treatment. They ended up using only Cytoxan. If you look at their overall response rate, really quite remarkable, close to 88%, with a very high percentage of people achieving complete responses. And again, this is the first time they're actually showing us data wherein they have a progression-free survival of about 16 months. If you look at patients who've achieved a complete response, that CR rate is close to 12, or that PFS, progression-free survival, is 22 months. I think there are subtle differences between this one and the 2121 data set, and the fact that these patients were a little less heavily pre-treated, given that it's largely a Chinese patient population and given what we know of what's available to them. So certainly they've had bortezomib and lenalidomide. As far as pomalidomide and carfilzomib is concerned, not that heavily exposed to those drugs, and certainly not seen CD38 monoclonal antibodies like daratumumab. But a slightly different population, but nonetheless, the data looks quite reassuring and very similar to the BB2121 data set. We do have others as well, Gina. The JCAR study is being presented. Again, it's a little bit early in its development, and again, using the same target BCMA. I think they've accrued about 19 patients, and they're presenting subset of those 19 patients here, and again seeing very high response rates. A little more toxicity with the JCAR CAR T, at least from what I could glean from the abstract. We'll wait and see what the data shows when they present it. I think it's being presented on Monday out here. But otherwise fairly manageable. CRS, neurotoxicity, and again high complete response rates. Obviously the follow-up in this patient population is a lot less, so we'll just have to wait and see. But it is an exciting time for CAR T-cell therapy for myeloma.
Good, and that was some great insight that you shared. Now looking at, there's also the phase 1 of BB21217. Can you discuss that study a little bit and the initial findings?
Sure. So the BB21217, Nina Shah, my colleague from UCSF, is presenting this tomorrow in a work session, And the difference between 2121 and 21217 is, this is kind of the next generation of cars, so to speak. And what 21217 is trying to do is see if by manipulating these CAR T cells, can we get more persistence. And the way we're doing this here is the CARs ex vivo are being exposed to a PI3 kinase inhibitor, which is called B007, and that's why the name BB21217. The idea being, by exposing them ex vivo to this PI3 kinase inhibitor, you are going to try and get more of a memory phenotype, and you're going to try and see more persistence of these CARs. Now again, we have about I think what Nina is going to be presenting at this year's ASH is close to 12 or 13 patients, and we've seen very similar efficacy results to the BB2121 data set. So same kinds of very high response rates to the tune of 80 and 90%. And again, the follow-up in this subset is also short, but we are seeing durable responses in this. As far as toxicity is concerned, very comparable to what we've seen with 2121. CRS was certainly seen. Very little, if any, neurotoxicity. We did have one patient with neurotoxicity, but all of it was reversible and manageable.
Great. Now you're also authored on an abstract of overcoming MCL1 resistance in multiple myeloma. Can you share information on that?
Right, so MCL1 is, in my mind, a really good target for multiple myeloma. The abstract you are referring to, Gina, is a preclinical abstract, so that's coming from my lab. At this year's meeting, you are going to see data with a BCL2 inhibitor, so venetoclax, in combination with carfilzomib. And what venetoclax does is targets BCL2, BCL overexpression. Generally, when you think about multiple myeloma, it's about 20 or 30% of myeloma which is BCL2 dependent. Rest of it is MCL1 dependent. What we've studied in the lab is a specific MCL1 inhibitor. This comes from AstraZeneca, this MCL1 inhibitor. And what we've seen is one of the resistance mechanisms of preclinically not seeing responses to the MCL1 inhibitors overexpression of BCL2. So BCL2 takes over, and the data we have is combining a BCL2 inhibitor with an MCL1 inhibitor, where we see absolutely remarkable preclinical activities suggesting that this should be tested in people as well. So venetoclax in combination with an MCL1 inhibitor may in fact be a game changer for the treatment of myeloma.
Very interesting. Now, you have obviously been very involved with the BB2121 studies in multiple myeloma. So as we continue to get more data and more follow-up of this product, how do you really see it affecting the paradigm for these patients?
So, that's a great question. I think all of us are struggling with that, but anything which kind of works towards the end of disease, obviously we try and bring it earlier on in treatment, and that's exactly what we are doing with BB2121. We've actually completed accrual to the phase 2 study. That was a very similar population to the phase 1 study, and we'll see what the data looks like towards the end of next year or early 2020. And as this study is maturing, we are already planning on some of the other studies. And the other studies, and you can check those out on clinicaltrials.gov, we have Karma 2 and Karma 3. Karma 2, we are focusing more on a high-risk patient population, and we're trying to get that high-risk patient population very early relapses we're treating with the CAR T-cell approach, because that is a patient population with an unmet medical need. We know that that high-risk patient population has a very poor prognosis, and you can almost mark out the survival of these patients. So we're bringing it very early to those patients, and then again we are bringing it to the rest of the myeloma community in the Karma 3 trial, wherein we are bringing it in 1 to 3 lines of treatment. And I think this is really important, because you will at this meeting see triplets and quadruplets where the monoclonal antibodies are moving really way up front. So we are going to be using up all of this. So what we are going to do with BB2121 is studying CAR T cells in the 1 to 3 lines of treatment. So early relapse will be studied, and I do think that's going to be the future. Ultimately, I think what I would like to see with BB2121 or one of these CAR products, we don't know whether it's going to be the JCAR one or the Legend one or 21217 or BB2121, who knows, but can we kind of pitch it against an auto transplant and see whether or not we can replace an auto transplant with some of these approaches. I think all of these are just things which we will be studying in the very near future.
Great, you made some great points. Now, are there any other abstracts in multiple myeloma this year that you'd like to mention, or looking back at all this data that are being presented this year, what does this really say about how multiple myeloma treatment is really evolving?
You know, I say this every year, but it's no joke. Every year there's more excitement, and we always feel that this year is going to be sort of a slow year for myeloma, but we don't seem to be seeing that. Now, at this year's ASH, I do think there's going to be a practice-changing trial which is going to be presented as a late breaker. This is the Maya study, which we've all been waiting for, and it builds upon the first trial. Now, the first trial really did change the standard of care for the transplant ineligible patient population, where now the majority of people are using RD, so lenalidomide dexamethasone, as sort of the standard of care for this patient population. What Thierry Francone has done very nicely in this Maya trial is now to this RD backbone added on the monoclonal antibody, so daratumumab, and the trial is 700 patient plus, comparing RD Dara versus the standard of care, which would be RD. And you know, even the abstract, you have the PFS of the RD arm is close to 30 months, 31 months or something like that, and the PFS for the RD Dara arm is not yet reached at a very good mature median follow-up of about 28 months. So this again is going to be a game changer. We do have daratumumab already approved for myeloma in the upfront study setting, and that's in the context of the Alcyone data, where it was combined with VMP. So although there was some excitement in that Dara is approved in the upfront setting, you know, we don't really use VMP. VMP is not something, at least in the United States, which is standard of care. So the Maya trial is going to really open up the doors for the use of Dara upfront, I think. You know, there's other data which is being presented. For the first time, we're going to see ixazomib as a maintenance option. We've always maintained, given how well tolerated ixazomib is, it is in fact the perfect maintenance trial. There was no data, but at this meeting, Panos Demopoulos is presenting the Tourmaline data where ixazomib was compared to placebo. So I think a lot of exciting things which are being presented here, and which in fact will change how we take care of our patients with myeloma.
Well, Dr. Raje, thank you so much for being here today. You really shared a lot of light on some really, really interesting abstracts this year, so we appreciate it. Thank you for being here.
Thanks so much, Gina.